Good evening. We want to give a special warm welcome to all of our Wasatch Hills members tonight. Tonight, we've convened a panel of our in-house medical experts at Wasatch Hills SDA Church. And I just want to give a lot of credit to my colleagues here who've just donated a lot of their time tonight to be able to provide expert opinion on this very pertinent topic that we wish would all go away, but unfortunately we are faced with now a new wave of the Delta variant here in our own community. So I briefly just wanted to highlight the clinical years of experience on this panel. Not everyone will be on this panel tonight. A few are missing right now. Nathan Blue was called to an urgent case, and Lana McGill is sheltering in place. Her family had to evacuate because of the Parley's Canyon fire this weekend. So she hopes to be with us tonight, but she's in transition as she's settling into a friend's house. So, but if they arrive, I just wanted to highlight the years of clinical experience that we have on this panel. So I'm just going to turn over to some slides here just to highlight those of us that are on the panel tonight. I hope you guys can all see that. Okay, in any case, you can, the general gist of who was on the panel, and myself, Craig Chaya, we have Robert Blond, Derek Sakata, Lana McGill, Nathan Blue, Lisa Palmieri Stevens, and special guest, Scott Stevens tonight, and also Melissa Pender. And just between all of us combined, there is over 100 and probably, including Scott, probably 140 years of clinical experience on this panel alone. So many of us have been in practice for many years. And so, and this panel also represents a lot of different subspecialties as well. Okay, so now I'm going to turn it over to Bob. Let me just undo my share screen, and then we'll give you a chance to give some opening remarks for our discussion tonight and kind of the impetus for why we decided to do this panel discussion. Okay, give me just a moment.
Well, let me be clear as we start off that we are here as a group of Wasatch Church physicians because we are concerned about the health of our church family. The Apostle Paul opened his third epistle by stating, "Beloved, I pray that you may prosper in all things and be in health." That is also our wish for our church family. Historically and currently, our Seventh-day Adventist Church has been at the forefront of promoting healthful living. We believe that each and every individual should be allowed to make their own decisions regarding their response to the COVID pandemic. But we also wish that their decisions be based on factual information. There is so much misinformation out there, often promoted by individuals who might appear to be informed and qualified, even physicians, but give information that is not correct and very misleading. Our goal is to try to present the latest information based on valid scientific data, not conjecture or hearsay. At least 3 of our Wasatch Hills families that I'm aware of, perhaps there are more, have lost their loved ones to the COVID pandemic. One of the families lost 2 of their family members in one day. With the new Delta variant, the stakes are now even higher as to how we respond. There's no perfect response, but there is impressive data to suggest what is best to do at this time. The current data suggests that with time, everyone will be exposed to the COVID virus, and we need to know the most advisable ways to try to prevent major complications. There is impressive data to suggest what is most effective right now. Who can we trust? We believe the best scientific and medical information is what we should trust, and that is what we are here to present tonight.
Thank you, Bob. I'd like to also now just briefly read our SDA Church's official statement on vaccination. And it says that the Seventh-day Adventist Church places strong emphasis on health and well-being. The Adventist health emphasis is based on biblical revelation, the inspired writing of Ellen G. White, co-founder of the church, and on peer-reviewed scientific literature. As such, we encourage responsible immunization, vaccination, and have no religious or faith-based reason not to encourage our adherents to responsibly participate in protective and preventative immunization programs. We value the health and safety of the population, which includes the maintenance of herd immunity. We are not the conscience of the individual church member and recognize individual choices. The choice not to be immunized is not and should not be seen as the dogma nor the doctrine of the Seventh-day Adventist Church. With that, I'd like to now kind of give some current context of what's going on in our healthcare system. And Derek, I'm going to turn it over to you to give us a synopsis of, well, what are we facing right now currently in our healthcare system, particularly at the University of Utah, and what are the projection models looking like?
Okay, you want someone else to go first, and then
Yeah,
I can
let's, Scott, maybe you'll go first, and then while Derek has a few like pertinent slides that he wanted to show just in terms of projection models, maybe you could kind of give us a frontline view of what's going on at Intermountain currently.
Yeah, sure, I'd be happy to. And since I'm standing in unexpectedly, I'll be estimating the numbers from memory, so they'll be off by a little bit, but at least in general magnitude, they should be spot on. So Intermountain Healthcare as a system has returned to our surge response level of care with our various facilities ranging from 80% to over 100% capacity for the hospitals. And the ICU is actually somewhat higher than that, ranging from capacity in the 90s to over 100% capacity. And we're returning to redeployment and other measures to care for patients beyond our usual capacity to provide care. The hospitalizations related to COVID are between 90 and 93% unvaccinated individuals, and the entirety of the people admitted to the hospital with COVID who have been previously vaccinated are either elderly with multiple other health problems or are actually incidentally found to have COVID and not ill with it. So vaccination is both substantially reducing the risk of illness serious enough for hospitalization. And even in those who are ill enough to become hospitalized, they're having a substantial reduction in the burden and seriousness of illness compared to those who are unvaccinated. So while no treatment is perfect and no vaccine is perfect, there's unquestionable substantial benefit to having been vaccinated in the Delta era. And the burden to the healthcare system that we're presently wrestling with is largely due to care for patients who have not yet been vaccinated and have gone on to contract Delta. And Delta is at the moment essentially 100% of all the COVID in Utah. There's very few progenitor strain cases, and there's only been one Lambda in the state of Utah, at least as of the time I most recently looked at the data.
When you look at the Intermountain cohort of patients who are maybe insured by Intermountain, is there an approximation of how many of those patients are not vaccinated yet?
My assumption is with the proportion of the state that's covered by Intermountain, we probably mirror the state statistics in terms of number of eligible people with one vaccine or a complete set. I don't know that I have access to numbers that carve out just the population under Intermountain's care, but I imagine it probably doesn't differ substantially from the state as a whole.
And as you look at, compare this current wave with the first wave, the Alpha variant that first arrived, is there a change that you see in hospital course or duration for those patients, or just in general, the demographics of the patients that are being admitted?
Certainly, as I mentioned, there's a separation in the demographics of those who have contracted the disease after vaccination versus those who haven't. Those who have been vaccinated are older and sicker, but having a somewhat milder course of illness than we might have predicted compared to the first wave. The remainder of hospitalizations are somewhat younger, and younger people are somewhat sicker than we may have been used to seeing compared to prior waves. And I would point out in magnitude, we're actually presently in excess of the first wave. We actually have more hospitalizations and a higher percentage of beds filled, not higher than the summer, but higher than wave one in the spring when the pandemic first crested.
So explain to us what makes it so different, Delta variant versus the Alpha. What has really changed? Why it's a younger population of people that are getting admitted or maybe sicker?
Certainly would love to be corrected by our infectious disease expert who's on the panel, and I'm an internist. So please don't hesitate to jump in. But I believe there are several factors. The first is that the mutations in the Delta variant influence portions of the spike protein, which make it substantially more transmissible, probably similarly virulent to the parent strain, but affecting younger people probably for two reasons. The first is proportionally younger people are less likely to have been vaccinated than older people, and in part probably because the efficiency of transmission is likely to cause that to happen more frequently in younger people who are perhaps a little bit less careful with their masking and social distancing. But please add your superior knowledge to mine if you would.
No, I think that's a great summary. It's more of the population at risk are those that are unvaccinated, which tend to be the younger, and then those who are more likely to congregate in groups. We know that Delta is much more transmissible, and I think that's a big reason.
So for our panelists, those of you that are on the front lines administering therapeutics, let's say you're a patient that now is admitted for the Delta variant. Are the previous therapeutics that were available for treatment of COVID still available, and are they successful in this new variant?
I would argue that the options for treatment, especially of severe disease, are quite limited. And compared to vaccination, they're much less well studied. They have much worse safety profile and side effect profile than vaccination, and efficacy significantly lower compared to just prevention of disease in the first place.
Yeah, I would certainly agree with that statement. We have only one therapy available in the non-hospitalized setting, which is a monoclonal antibody infusion. And then we've gone through arrays of different therapies in the inpatient setting that have had modest efficacy, substantial toxicity, but any therapeutic intervention pales in comparison to the effectiveness of prevention.
Right. So this is all of us probably understand this, but I think it's important for our members to understand if you get admitted.
Pizza's coming out of the oven and I haven't eaten yet, so I'm going to take it out before it burns and then I'll come right back.
Okay, sounds good. So my question for the group is, I think some of our members may not understand the purpose of vaccination in terms of prevention and may think that it could be available at the time of actually getting sick and being admitted to the hospital. Melissa, what is when you are admitted to the hospital with active COVID, is that the time to be vaccinated, or is there a time while you're hospitalized where you could be eligible for the vaccination?
Actually, we don't recommend vaccination once you have active COVID. We typically do recommend vaccination to all patients that have COVID, but we postpone it to a later date and wait until after your recovery. So it really pushes out your vaccination no sooner than 10 days and potentially as long as 3 months after your initial infection.
And that actually puts me in mind of another piece of misinformation that I think is fairly common, which is that for some reason it's preferable to be exposed to the disease and develop natural immunity rather than being vaccinated. And really, I think the science very clearly suggests that that's not the case. The immunity provided by vaccination appears to be both more effective and more durable than the immunity that derives from having been infected. And then, of course, vaccination doesn't carry all the risks of getting infected, such as severe disease, severe lung injury, long COVID, and then the numerous other sequelae that unfortunately can burden some people after even after recovery from the acute COVID infection.
Okay, great. Thank you so much, Scott. Appreciate your perspective. Derek, ready to roll here?
Yeah, and before I roll, it looks like it'll work now. Is the therapeutics on the outpatient side, the monoclonal antibodies, those are being done at University of Utah Health as well as Intermountain, I believe, Scott. There are criteria that you do have to meet to be able to get those infusions. So in addition to my jobs as an anesthesiologist, I'm the executive medical director for healthcare for all the Southern delivery of University of Utah Health Ambulatory. And we do this out of our South Jordan facility, but there is pretty stringent criteria that are needed to be able to meet to be able to get a monoclonal body infusion. So just want to give you that. Any questions on that before I start on the slides here?
Yeah, so despite, having been through this for the past year, despite all the advances for therapeutics, as I'm summarizing basically that we have limited therapies other than supportive care if you're admitted to the hospital for COVID.
That is correct.
It might be a good idea, Craig, to define supportive care. Remember, we're talking to non-medical people.
Sure. I mean, Scott, you guys are on the front lines. I'm saying that as an ophthalmologist, I kind of have it in my head what supportive care is, but maybe you could describe for us what supportive care means for patients when they're admitted to the hospital.
That generally means any interventions we undertake in a hospitalized patient that are meant to support the function of the body rather than directly targeting the infection itself. And so this would include, something as simple as IV fluids, pain and fever relief, but probably much more importantly, high flow oxygen, mechanical ventilation, which is a ventilator taking over much of the function of the lungs, or in the most severe cases, ECMO, which is a system that actually bypasses both the heart and the lungs to both provide oxygen to the body and remove carbon dioxide.
Okay, so it could be from very benign treatment, things that we would consider even over the counter, to very invasive supportive care.
Correct.
Okay, great. Derek, you're up.
Yeah, and then one other thing I'd add to that, it's really important for people to understand when we place a breathing tube. So that's something that we do as anesthesiologists, that you need to be sedated for that. And being sedated and being on a breathing machine for a long period of time, especially ECMO, where you bypass the lungs, the recovery from this is an extended period of time. And you may not ever actually get back to normal if this occurs. Even when we put people to sleep for anesthesia for just a couple hours, especially if they're elderly, it can have a direct toll on them. So with the disease process that's going on, plus being put to sleep, plus being, plus having a breathing tube, it's a big deal. So with that, you can see my slide page up there. Is that correct? Mm-hmm. Yes. Okay. So I have to say that I borrowed this from Dr. Russell Benick, who is our Associate Chief Medical Officer, and he was kind enough to share these slides with me. So it's important to understand that as we have gone through this COVID scenario that we're going through, disease process pandemic, that the number of cases had gone down and are starting to go back up again. So if you look at the very bottom down through here, the x-axis, we're going from June to August of this year, and we can see that the count, which is shown here, is starting to go up by about threefold. So the number of cases that we're seeing per month is going up. Now, it's one thing to say that cases are going up. Let's see if I can get these slides to advance here. And it's one thing if the cases are going up, people are getting sick, but they're not getting hospitalized. I think, and my colleagues can correct me if I'm wrong, that would be the best case scenario where people get sick. They may get some sort of resistance to the disease, but not get hospitalized. The problem is when we start to get these hospitalizations that occur, you can see in the same time frame between June and August of this year that the hospitalizations are also going up in the state of Utah. It's also important to understand that this is the worst part where we had the pandemic at the worst. We are going up. We're not quite going up as fast as we did last autumn. And that's probably because we have people who have been vaccinated. But at the same time, realize that these numbers are going up. The other thing I have to let you know from an administrative standpoint is that we are severely low of healthcare providers. Scott, are you all like that at Intermountain?
Yeah.
How many open positions do we have right now?
You know, yeah, we have hundreds of open positions for various healthcare professionals. Yeah, so we're definitely strained for people to provide this care.
Yeah, so even though our numbers aren't going up as high, we have numerous people who have left the profession. We're about 1,200 people down in University of Health right now. Our chief medical officer, Tom Miller, stated that in the state of Texas, they are down 21,000 nurses right now. We are down about 40% on our techs in the operating room. Those are the ones that actually scrub the surgery to do the surgery. We had to close down one of our ORs in our neurosurgery ORs last week, every day, because we didn't have enough people to actually do the cases. And this is, you know, if you have brain cancer or other things that really need to be treated, this really is a big deal. We just don't have the people to be able to run the COVID like we did last year, plus be able to keep everything else going. So what about flu and RSV? My friend Lisa there can talk about the RSV, but in general, flu, if you go to the public health website here in Utah, it's about 200 admissions per month. And we see flu start about October 1 and go through about April 30. So if you can imagine adding on to that volume that we already have, that's a big deal. The other thing we're starting to see is that COVID is starting to affect our children. And with that, more hospitalizations are needed, and sadly, even intensive care unit admissions. So with RSV, generally January through February, I think Andy Pavia said it best, and Becker's, you know, last year we hardly saw any of this. But with the measures we don't have in place as much, such as masking and things to keep these diseases under control, we're going to see more. So it's about 80 admissions per week during this time period for RSV. This is again, a viral disease that affects children that makes it hard for them to breathe. So Lisa, is this about the right thing we're seeing here for RSV in general?
Yeah, we started our RSV season. Primary Children's officially announced the opening of RSV season based on a number of cases that they were seeing. This is very out of time. We usually are in January, and this is in August, which means our premature and vulnerable children are at risk not only from COVID, but also from RSV. And RSV causes profuse runny nose. Those secretions get into the lungs and the children cough so hard they can't breathe. And they wheeze and they need oxygen. And so we really dread this time in January or February. And there's not a vaccine that's available for this. Some of our sickest kids can get some antibody shots, but they have to be extreme premature infants. So most average infants are at risk for this illness. But then we add on top of that the COVID risk in addition, and this could potentially be very disastrous for us.
So that's exactly right. So in addition to fighting COVID, it's also important to get the flu vaccine. So as you get older, flu is going to have more of a devastating effect on you. So flu vaccines, all these vaccines can help you be able to fight these diseases a lot better. So if we look at about the hospital census in the state of Utah, you can see that it's starting to go up. Now of note, it's hard to see in this graph right here as we're in July here, this is January here. The number or percentage of ICU patients, although this total number is not going up, there is about 6 or 7% higher risk of being in the ICU with the disease processes with COVID right now. Is that something that's backed up, Scott, you're seeing there, or I didn't hear if you see more ICU patients?
Could you ask that question one more time, Derek? Just to make
We're
sure.
seeing a higher percentage of ICU patients now than before, so going into intensive care.
Yeah, the percentage of cases that were in the ICU had dropped, as your graph shows, and then relative to the total number of COVID hospitalizations, those in the ICU are starting to go back up again. We're seeing the same thing.
Yeah, so that's really concerning because it's number one, it's younger patients, and number two, they're ending up in the ICU or intensive care unit a bit more with higher level care needed. So that's something to be aware of as well. So in general, the inpatient trends are going up. You can see this is where we were at the height of the pandemic. We're starting to go up Again, we have not entered the flu season yet, so presumably that might add to some of these numbers here as well, even though they aren't COVID. And it's interesting to say too that flu presents like COVID. And this coronavirus you hear about, coronaviruses are responsible for most of our colds, the regular colds. So those are going to come back as well and also look like coronavirus. So these are going to start to make it more difficult for us to diagnose our patients. This graph down here in the bottom right shows kind of what happens in terms of the number of patients that are positive. And you can see that the orange shows that those that are unvaccinated have a higher predisposition to becoming having an active COVID sort of presentation or being COVID positive. So that's something to be well aware of. And up here at the top, you can see the green numbers are those that are fully vaccinated. So it does allow some immunity. The last slide I have here is from the Utah Department of Health. And I think it's really important to understand, and I just saw this today. I didn't know they had this on their website, but if you look at the yellow bar up there, 5.6 times. So you're 5.6 times greater risk for testing positive for COVID if you're not vaccinated. You compound that with 6 times greater risk of hospitalization, and then 8.8 times greater risk of dying from COVID-19. I think these are large numbers that we would hope as physicians that we will not start to see our patients get into these sort of numbers, because these are multiplication factors of risk, which are quite scary. So that's about all I have for my slides. I'm willing to take any questions.
Well, that's a little bit sobering, Derek. I was hoping for better news, but this is the reality of what's going on in our healthcare system. I think, as an ophthalmologist, what affects my patients and what affected them during the pandemic is when we were shut down for elective surgeries. Most of what I do is elective surgery. And what I saw in the middle of the pandemic, as we were kind of emerging, is patients who either chose not to seek general care for their eye conditions, chronic diseases, and those that were just plain fearful of entering any healthcare facility because of the fear of contracting COVID. And unfortunately, we saw numerous cases of patients whose vision had deteriorated that could have otherwise been prevented had they come in. And whether they had been vaccinated or not, I think many of them had delayed care during that time. And I think this is a real crisis for patients to understand, or a real crisis for our members to understand, that although chances are, if you're healthy, you have good fitness, chances are you're going to survive COVID, but you have to think about all the other ramifications to your health in terms of your inability to get general care or to get preventative care, primary care, if we are in the midst of a huge pandemic with a workforce shortage.
One last story I'll just tell is that Intermountain and University Health, we are centers that accept patients from our surrounding states for sick patients. Last week, there was a patient in Idaho who was in heart failure. His heart was only injecting 10% of the blood that was kind of coming in and out to the rest of his body. They called around for him to be, could we take him at University of Utah Health? We could not because we had no beds. We told them to call Intermountain Health. Intermountain could not take him either. And they tried and tried, could not get this patient in. They finally let the patient know to call California to see if they had a bed. The patient said, I don't want to go to California to die. I'm just going to stay here in Idaho. Because right now, I don't know what's happened to the patient. He didn't have COVID. He's 27-year-old with a heart disease. And this has happened, excuse me, all the time. Oklahoma asked us to take a patient to University of Utah. We were number 57 of the hospitals that they called to take this patient. So this could be your loved ones, and it's pretty profound.
Right. Okay.
Could I just add one more?
Sorry, Doug.
Sorry for the background noise there. Just wanted to address what I think is a piece of misinformation about masking.
Yes.
I normally like to talk about data and studies, but instead I'm going to share a personal story because I think it reinforces what the data shows. I personally was in the same room with nearly 100 different patients with COVID, including patients on ventilators. before I was vaccinated. And I was good about wearing my personal protective equipment, and I never caught the disease.
Impressive.
Okay, we're going to transition. Nate, thanks for joining us. We appreciate you making a very just strong effort coming out of the OR to join us. I'm going to give you a little break to just kind of catch up as we listen to the rest of the panel discussion. Lisa, I'm going to transition over to you. It's mid-August. It's back to school time, and we've got a lot of kids heading back to school. As a general pediatrician, first off, what are you seeing in the clinic? Is there anything that's concerning you about what's happening in the clinic in terms of what you're seeing? And then also, as we think about parents that are getting their kids ready for back to school, some tips maybe that you could share that may help to protect them and provide some protection, especially for those children that are not eligible for the vaccination yet.
Sure. So COVID is a mild disease in children, and we're all, as a country, very grateful for that. That's true in most of the cases. It's not 100% true. So I have not seen a lot of very sick children with COVID, with the exception of one patient. He had the multi-system inflammatory disease. I'm not sure how many parents are actually aware of this. The ones I'm talking to in clinic don't seem to have understood this very well. So COVID, part of the reason you get really sick with it in your lungs and other places is your body overreacts to the virus, and it becomes violently angry over something it should be only moderately angry over. And in children, for some reason that we don't know, instead of just leaving that anger to the lungs like it does in adults, it can hit the heart, the liver, the kidneys, and the brain. And my little patient came in with clear signs of meningitis and was in the hospital for several days and had an attack on all of those organs. He did well long term, but he will be followed by cardiology probably for the rest of his childhood to make sure his heart stays safe. And not everyone who goes through that comes out okay. In the state of Utah, with the first wave, we had 400 cases of this MIS-C. It's called MIS-C, MIS-C. And of that, there were 3 deaths. So I'm sure every one of those parents would have not wanted to go through this. All those children are ICU patients. They are very, very sick. They have multiple IVs and multiple lines, intubated some of them, many, many specialists. So if there is a way we can keep our children from catching this illness, I'm sure that most of us would do anything to prevent our children from having this. And vaccinating the adults is one way to do that. And also vaccinating the kids between the ages of 12 and 18 who are now eligible for the vaccine. The second big concern pediatricians have is the decision by the Salt Lake County Health Department, Salt Lake County Council to rescind the health department's mask mandate, which means children under the age of, all kids in all school are not going to be required to mask. So I tell my parents to plan on getting Delta if you're unvaccinated. You will get it. Your children will be exposed and they will bring it home. So I ask parents, do you have the time for this illness? Do you have the finances if you get a more significant illness to make those payments for the hospital? Can you miss that much work? And that's been able to help some of my parents make the decision to vaccinate. Then we have RSV starting, which we don't know what RSV plus COVID looks like. We don't know what it looks like when a child gets both of them together. We didn't have RSV because we were masking. So masks clearly prevented disease. In fact, masks prevented such a great amount of disease that pediatricians were hurting for patients. We're used to a very busy fall and winter, and we had almost no viral disease. I don't think I saw a single flu case the whole winter, which is really unusual. So people who say that masks don't prevent disease are not, they're not telling you the truth. They really, really do prevent COVID and RSV and flu and croup and all those other illnesses that transmit so readily around a school-age population. In addition, I want to speak to the safety of the vaccine for the 12 to 16-year-old range. And I know people have been concerned about the heart swelling, that heart inflammation that's occurred in some cases. Dr. Pender know the data better, but I thought it was about 6 per million doses is what I had seen in the data that I saw. So it's a rare complication, but a serious one. You take a kid who hasn't been sick and you give him the vaccine and he gets the heart inflammation and you feel like you made a terrible decision. But that Missy that I described at the beginning, that causes heart inflammation at a much higher rate. So it's not like you're choosing between not getting heart inflammation and staying safe and not getting the vaccine, or getting the vaccine and getting heart inflammation. By choosing not to vaccinate, you're increasing your child's risk significantly that they will get the multi-system organ failure problem. We are expected 3 to 4 hospitalizations per week across the state of Utah, these mostly being ICU kids, as soon as this starts to peak. So we're anticipating that in the next month. Again, those hospitalizations mean there's not room for my other special needs kids to come in. The last thing I wanted to say is that as Christians, we firmly believe in our ability to take care of the most vulnerable among us. And I have so many kids in my clinic that can't vaccinate because they aren't old enough and who are desperately ill, and their parents have been now terrified for more than 16 months about them getting COVID. These are children with heart transplants and autoimmune diseases and lines and tubes. And they are heartbroken when they see that others don't vaccinate to help protect their child. I can't speak to it from the elderly, but I know that it causes a lot of pain and suffering to feel like the community is not behind them and surrounding them and doing everything they can to help keep their special needs kids safe. So as we think about making our decision, part of it is about our own health, but part of it is about the health of the most vulnerable among us. And that is truly what we're called to do as Christians, is to put ourselves out to protect the lives of others. So I would implore people to strongly consider getting the vaccine for the safety of their children and for the safety of other people's children.
Thank you, Lisa. Such important information for us to really put in perspective. I think as Americans, we pride rugged individualism and freedom of choice. But I think it's important for us to realize that we're a part of a community. And obviously, some of us choose not to be a part of a community, but those of us that believe in not only our church community, but our greater Utah and Salt Lake community, we want to know ways that we can be helpful to put this pandemic to an end and to really return back to normalcy. And you've highlighted so many important reasons why we should consider that, especially as we head into back to school season. Questions for Lisa from any of our group before we transition over to Nate? Okay, Nate, you're on. So, Nate is our resident expert, OBGYN, does a lot of maternal fetal health and is a high-risk OB specialist. And so, Nate, you've been seeing this, something that I wasn't really aware of is the impact of COVID on pregnant, expectant mothers and even newborns.
Yeah, that's right, Craig. I hope everyone can hear me okay. Thanks. So yeah, I'm a specialist in maternal fetal medicine or high-risk pregnancy. And so I am part of the group here at University of Utah down at Intermountain Medical Care of our state's sickest moms and babies before they're born. And we are actually admitting more moms who are pregnant to the ICU in the last month than we have in the entire pandemic. We are seeing them very consistently, and virtually all of them are unvaccinated. It's tricky because pregnant people were excluded from the trials that the FDA emergency approval was based on for the mRNA vaccines and the others. And now we have a good amount of reassuring information. More than 100,000 pregnant women have received the vaccine who have been tracked, probably many more than that, but at least that many who we have paid attention to and followed up on outcomes and made those data available. And there is no evidence of any safety concern either for something focused on the pregnancy, like birth defects or prematurity, or anything to that effect, as well as for just general reproductive considerations such as fertility. And I should have mentioned also miscarriage is something that we are not seeing any evidence of. So we have pretty reassuring information with respect to its use during pregnancy. And we also have, I should say that there has not really been any serious scientific or theoretical concerns. There are many drugs that are not tested or studied in pregnancy, where the reason for that is because there's a very specific concern that we think can cause harm, but there is really nothing like that. There are people who sort of come up with theories, but none of those have been considered to be plausible, and none of them have shown up in any of the information that we've been tracking. The last thing I just want to mention is that COVID in pregnancy is very serious and seems to affect pregnant women much more seriously than in their non-pregnant counterparts who have similar age and similar degrees of health conditions and diagnoses. Moms who are pregnant who get diagnosed with COVID are more likely to be admitted to the ICU, to require intervention like intubation, and are also much more likely to require premature delivery, which we know also has serious consequences for newborns and that last throughout childhood and across the lifespan. So we're kind of in a space where a lot of people get scared off by the uncertainty or the lack of very long-term information on pregnancy, but they are sort of, I think psychologically that has a lot of prominence. But if you think about what we know that the risks are serious, and those are very well described of COVID in pregnancy. So you have known risks of getting COVID, which, as Lisa pointed out, we all eventually will if we don't get vaccinated. And we have reasonably good safety information. And so recently, because of all of this, of what I've just summarized, our main professional societies in the United States that sort of write the clinical guidelines for obstetrics and reproductive care, which are the American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine, have both actually formally come out strongly in favor of vaccination during pregnancy. Whereas before, they promoted shared decision making and everybody sort of coming up with, deciding based on their own perception of their risk and exposure in conversation with their healthcare provider. But now they're actually advocating for it strongly because it is safe and it is very effective at preventing the serious complications.
Is there a time period, Nate, when pregnant mothers, expectant mothers should be vaccinated? Is there a certain trimester when it's advocated for, or just as soon as you find out you're pregnant?
Any time is acceptable. There are no described or theoretical risks that would apply. So if somebody is presenting to get health care because they've recently found out they were pregnant, then that's a great time to have that conversation and get vaccinated.
Great. Any questions for Nate? All right, now we're going to move into a very pertinent one. We've been talking about the benefits of vaccination, but I think it's important for our members to understand how vaccination works. And so Melissa is our in-house infectious disease expert who's finishing up her infectious disease fellowship this coming year. And Melissa, we've had a number of vaccines come to the market. What is currently available in the United States for our population?
Yeah, absolutely. Let me share my screen briefly in case anyone wants any additional handy infographics while we're chatting about vaccine mechanisms. So there are 3 main COVID vaccines that are available. 2 of them are the mRNA vaccines, which are the Pfizer and Moderna, which are a series of, right now, 2 vaccines and discussion of an ongoing potential booster to these. And then the third option is the Johnson & Johnson vaccine, which is a slightly different mechanism called a viral vector. So what traditional vaccines do is we inject dead or weakened organisms that then our body recognizes as foreign, and it ramps up the immune response, which is why we often get fevers and feel sick after a vaccine. But in contrast, the Moderna and the Pfizer vaccine have a slightly different mechanism. They use this mRNA, which is basically a code for proteins. Now, mRNA is normally produced in all of our cells. It's essentially the message that gets sent from our DNA that we need a specific protein to be made. The messenger RNA goes out to the protein production portion of the cell, and it is destroyed once that protein is finally created. In the setting of the Pfizer and Moderna vaccines, the vaccine includes this mRNA code specifically for the spike protein of the SARS-CoV-2 virus. And the spike protein is the protein the virus uses to get into our cells. So we try and target and recognize it and train our body to recognize it with antibodies. So the mRNA that's injected in the vaccines actually goes into our cells, goes to that protein production portion of the cells, and turns into a creation of the spike protein. The mRNA itself is fully degraded. It does not affect our DNA at all. It is destroyed. And then the spike protein is actually made by our own cells, presented to our immune system so that our immune system can form antibodies against it and protect us in the future.
So what makes I know some of our members have questions about, should I get the 2-cycle vaccine or the single shot? What is the big difference between the two? You've already alluded to slightly different mechanisms, but ultimately doing the same thing of presenting a spike protein to our immune system. But what's the big difference between the two?
So the Pfizer and Moderna are a little bit better studied in the setting of some of these new variants like the Delta variant. And they are right now a 2-vaccine series. There's likely to be a 3rd booster recommended. In fact, it already is recommended for, or at least available under emergency use authorization for some patients with immune system problems. The Johnson & Johnson vaccine is a little bit of a different mechanism. It's called a viral vector. And essentially what happens is it still encodes or trains your body to make the spike protein itself, but it packages it a little bit differently. And it packages it inside a common cold virus that's been weakened. And the common cold virus is how the spike protein instructions actually get into the cells. The reasons why someone might choose a Johnson & Johnson vaccine are if they only want 1 shot, or if they are potentially allergic to any components of the mRNA vaccines. We certainly had some patients that have had a reaction potentially to one of the 2-shot series and then finished off with a Johnson & Johnson vaccine a bit later. But essentially what we're telling folks is whatever you get at this point is what we recommend, whatever is available to you and whatever you feel most comfortable with receiving.
Is there a reason why, let's say you decide to get the 2-shot cycle mRNA vaccine? What happens if, a lot of people are getting sick after the 2nd shot, but what happens if you get really sick with the 1st shot? Is it contraindicated for you to have the 2nd series?
It depends on why you're getting sick. So a lot of people will develop an inflammatory immune response to either one of the vaccines. And even if you develop reactions to the first vaccine, it does not necessarily mean that you will develop the same symptoms with the second. There's no contraindications provided that this is not an allergic reaction. That's why we monitor patients carefully for at least 15 minutes, if not longer, after your vaccine series, is that we're watching closely for potential allergic reactions. It's really the allergic reactions like the throat closing, inability to breathe, anaphylactic response that is the contraindication in the future.
So I think some of our members have been waiting on the sideline primarily because they're concerned about how fast this vaccine came to the market. And I think it's important for our audience to understand maybe the levels of how an FDA trial is executed, and were any steps cut short in how these vaccines were rolled out under emergency use authorization.
So I'm happy to discuss my understanding of the FDA trial, and if anyone else is more informed, you're welcome to join in. There are a variety of different phases that any drug, including vaccines, go through. And they start with preclinical studies, which are usually animal models or laboratory bench science, testing out the science. Then there's a phase 0 where they test a small dose of the drug on a very low dose on a few people just to see if there's any response or what is tolerated. The phase 1 safety trial is the next step, where you start off with a low dose and you gradually go to a higher dose. You're specifically looking at safety concerns. The phase 2 trial has quite a bit more people, and you look for potential benefit using the best dose that you found from the phase 1 trial. And then the phase 3 looks at a large number of patients, usually hundreds to the low thousands. But in the case of the COVID-19 vaccines, we're looking at 30,000 plus people that were involved in these later stages of trial. So huge volume of people. The reason the COVID vaccines were expedited so quickly is that we have actually been working and preparing for an event similar to this with a similar class of virus to this. The mRNA technology has been, again, in development since the 90s. And in the last 10 years, we've been optimizing it to use in situations of outbreaks. Actually, even before the outbreak in Wuhan, the NIH had already prepared a basic recipe or a basic protocol for specifically coronavirus family diseases using this technology. So we already had the model in mind. So within a month after the outbreak in Wuhan, we were able to start initiation on vaccine creation. In addition, we were able to start manufacturing the vaccine at the same time that the safety studies were ongoing. And so that by the time we finished the safety studies to the level that we could get this drug approved for emergency use authorization for the general public, the vaccine was already produced and ready to roll out. And the safety studies have been investigated with such a high volume that at this point in the United States and around the world, it's one of the best, if not the best vaccine study that we have.
I mean, just in the United States, how many doses have we administered just in the US alone for COVID-19?
That's a great question. I wish I knew the rough estimate off the top of my head, but it's got to be on the order of millions around the world. We have a huge database of individuals who we have successfully vaccinated, and a very large cohort that we are still actively monitoring for long-term effects. That being said, most of the time what we've observed from other vaccine studies is that if there are any adverse effects, they usually occur in the very short period of time right after vaccine administration. So we are well beyond that point.
And Melissa, if I can add to your great overview, which was wonderful. FDA approval is actually not the end of what we learn about medications. Sometimes the moniker phase 4 trials refers to observing what happens to a medication when it's actually out there and being used in practice through surveillance of individuals who receive a medication and safety reports that come back to the FDA. And so when phase 3 studies are complete and the FDA approves a medication, in the phase 4 period, we'll often see data coming back on tens of thousands or hundreds of thousands of uses of a medication, and sometimes new safety concerns are revealed. In this case, we've had close surveillance of actually hundreds of millions of vaccine recipients, which is multiple orders of magnitude above a usual phase 4 level of observation. So much so that the very small risk of blood clots that was seen after the AstraZeneca and subsequently the Johnson & Johnson studies in Europe, they were able to detect blood clots occurring in 1 person out of 5 to 6 million doses, which is incredibly accurate surveillance. I mean, I think we've just really not seen the like of this before. So we can detect adverse events from vaccines with incredible precision because of the number of people that are under surveillance after receiving them now.
I was wondering if I could ask the question that I get asked the most commonly, and I think you can probably respond to it. You did already, but I think coming back around to this, many of my parents say it was developed too quickly and I want to wait to see how things work out. What advice do you give people to saying, I'm going to wait and see about long-term side effects with this vaccine?
Great question. And I think it's a very valid one and a concern that a lot of people have. What I typically tell patients is that this is currently the best studied vaccine that we have, not necessarily for COVID, potentially for any of our vaccine preventable illnesses. And the side effect profiles are so rigorously evaluated. Also that we've been following at this point, vaccinated individuals for multiple months, 8-9 months, coming up on a year without major long-term complications identified.
And Derek, maybe you could also add just, I think, again, to address the concern of how rapidly this vaccine was deployed from a business side. I think this is unprecedented what happened on the business side to make this vaccine available to the community.
Yeah, to that point, I mean, there's been about 190 million vaccinated doses of first pass, so to speak, in the United States, and about 160 million of Americans got the second dose, adults. So to get this out this quickly, from what I understand it, and from a business standpoint, it makes sense. Is the United States government basically backed this trial, right? Or backed manufacturing this drug. Whenever we undertake some sort of project to get some new drug or new device out there, it's a risk. We get investors who say, well, you give us so many millions of dollars and we'll get this product out there and we'll see if it sells. We'll see if it works. But in this case, the United States government and the previous administration should be given some credit for getting this out there, that they said, we're going to basically make it so that your bet, if it doesn't work out, we'll cover you. And that's what the United States did. It was a gamble, both with Moderna, also with Pfizer, but it did work with the backing of the United States, with the financial resources from the United States and the EU to get this done.
Right. Melissa, back to you, a question that was asked by one of our members, and this is a little bit of a scientific question, but there's some concern about this phenomenon that happens when you vaccinate patients, that it actually may enhance the ability to acquire the infection. It's what's known as antibody-dependent enhancement. You think you can kind of simplify that for our members and help them understand, is that a real risk for the COVID vaccine? Or have we encountered that with other vaccines before?
Sure. So antibody-dependent enhancement is a phenomenon that we observe naturally with certain infections like dengue, which is a mosquito-borne tropical disease. But it was also a phenomenon noted with very early measles and RSV vaccine trials before current measles vaccines. And what they noticed was that once an individual had antibodies against a specific infection, if they were in contact with a slightly different strain, they actually had worse symptoms and worse outcomes, which is the exact opposite of what we want with vaccinations. Why would we administer and develop antibodies if they're actually going to make symptoms worse? What we've actually learned is that it matters what type of antibody we target and what type of antibody we create. So the goal for specifically COVID vaccine, but all of our vaccines that we have approved, is that we want to target the creation of neutralizing antibodies. Antibodies that attach to the organism, neutralize it, so they prevent it from causing infection. And that is a significant, antibody response that reduces and nearly eliminates the risk of antibody-dependent enhancement. So the way we design vaccines now is that we specifically look for these specific targets that we can form neutralizing antibodies against, and we're very intentional about what targets we select. We test them on animal models to assess for antibody-dependent enhancement. And then by the time these vaccines are approved and tested in human models or in the population, we monitor for that response as well. But by this point, we do not expect the mechanism of our COVID vaccines to contribute to antibody-mediated enhancement.
Great, thank you. Any questions for Melissa before we wrap up? We're just about out of time now.
I want to say that I really enjoyed Melissa's presentation. I learned a lot, so thank you.
Yeah,
you very much.
You're a great lecturer.
Yes. And just to summarize, Melissa, could you just tell us who's eligible right now for the vaccine? Are there some patients that maybe should not get vaccinated?
Absolutely. The only patients that we are saying strict contraindication, no vaccination, are patients that have had an allergic reaction to the vaccine. Everyone else above the age of 12 is eligible, and there are ongoing trials to get emergency use authorization for younger children, as we alluded to earlier. There are certain populations where we recommend deferring vaccines, and those can include patients that actively have COVID right now. We tend to recommend that you wait till you recover. And again, that time period depends on the severity of your infection and what treatments you received. We also recommend that patients who have solid organ transplants or bone marrow transplants or other severe immune system problems that can't mount a good antibody response, that in these patients, we delay vaccination for a period of time. So that's why it's really important for these patients to vaccinate their communities and vaccinate those around them to provide them with additional protection.
Can you talk about the new third dose recommendations?
That's a brand new recommendation that just came out. And as far as I know, at least at the University of Utah, we have not yet started rolling that out, but it's a third booster shot specifically for individuals that have immunocompromising conditions or conditions where they are not likely to mount a good immune response. The goal of this extra booster shot is to try and trigger their immune systems yet again to extend or trigger them to produce more antibodies than they may already have produced, or they may be likely to have a low response. It's possible and likely anticipated for booster shots to be available on a larger scale to more patients than just with those with immune system problems. But that's also playing into the ethical component as well of vaccine distribution around the world. There are a lot of other places that don't even have the luxury of vaccinating their population with one vaccine. So there's certainly a lot of ethical dynamics that go into distribution.
Can you also comment on egg allergies and Guillain-Barré?
Other than, I guess, not specifically with the COVID vaccine, I wish I knew more details about it. In general, with certain vaccines that are made with some certain egg products, we recommend that if you have an egg allergy to avoid those vaccines. As far as I'm aware, there's no egg products that are used in the creation of our mRNA model, so I'm not aware that's a problem. I have not looked extensively, though, into that. If anyone else knows off the top of your head.
Yeah, egg allergy is not a contraindication to the vaccine.
And I'm not sure on the details on the Guillain-Barré. I have not seen that be a typical concern that we've talked about. But again, if anyone else is more informed, you're welcome to chime in.
Yeah,
I would like to ask the panel one further question. We've heard a lot of reasons tonight why people should get vaccinated, and yet approximately 50% of the adult population is hesitant to get vaccinated for reasons that aren't totally clear. I'm sure there are multifaceted reasons, but there's a lot of reasons that people don't have the trust in the medical community. What can we do to improve the trust in the people who really have the information that people should listen to?
Well, I guess one thing I would say, Bob, is well, I think there is a great deal of thought and passion that goes into people reflecting on their decision making. And while I believe that good medical care is always a team sport where the physician and the patient ally with one another to make the best decisions possible for the patient's best benefit, it's not that often as a physician I get to tell patients that I myself have had the treatment I recommend, but I'm voting with my feet. I've been vaccinated. I had the Pfizer. So I feel confident giving advice to patients that I am clearly willing to follow myself.
The other thing I think that's been really helpful for me in conversations with families who are vaccine hesitant is to know that I have a longstanding relationship with them and that I've been trustworthy on other things. So I can be trusted on this. My approach has been to simply say, here's what I'd like you to learn about it from me, and I won't bully you. And that's important. Nobody wants to feel bullied or humiliated or made to be silly, or that their ideas or their thoughts are not important. But it's also important that I tell them, you're paying me to digest the science for you and to be able to tell you what's good science and what isn't. That's what you pay me for when you come in. So that so far, most of the time has been okay. I've had a few kind of irate and unpleasant people still who don't want to discuss it at all. But I'm hoping that my long-term relationships with families will help that. And I hope that in our church, as we're talking to you as well, that the fact that you know us and that you know that we have taken the treatment and you know that we have studied and we understand the science and that we're giving you our best information, that also helps as you're thinking about your decision, that you have other trusted people that you can lean on for information. And any of us would be happy to take questions at any time.
And
And
Bob,
another thing that might be helpful is for people to recognize that of the 20 physicians that I'm aware of that are members of our church, I'm not aware of any that have not been vaccinated.
I think it's a good point, Bob. What Scott said, when I have a patient, one of the scariest times you can have when you're going to undergo surgery, and then someone like me is going to put you to sleep or do a spinal on you or whatever else going to do, and patients are scared or they're too sick to get an anesthetic. I will counsel them, just ask me what I would do if I were you, or if you were my mother, or if you were my child. That's always the right question to ask your clinician, because it puts them in that mindset of, yeah, if you were my family member, what would I do? And I always counsel patients to ask that type of question. So that's exactly what Scott was talking about.
And we vaccinated our daughter. She was 16 at the time. Within days of it being released for the 16 and older, we couldn't get there fast enough.
Right. And one more question that I had, Melissa, regarding boosters, because I think there is precedent for boosters. I think people need to understand that we have several vaccinations that we administer that we give boosters to. Could you maybe highlight a few of those?
Absolutely. So there's certainly a lot of the childhood vaccines that I think Lisa could go into more detail, but at least for adults, there's, for example, the hepatitis B vaccine series is a multiple shots. The shingles vaccine series that actually came out a few years ago as a new update is a 2-part series. And there are multiple other examples of vaccines that we commonly give that require multiple doses. These are studied at specific and given at specific intervals to try and trigger your immune system to provide the best long-term antibody response possible.
Great. Thank you so much. Well, I appreciate everybody's time tonight. We know that we are concerned about our community at large. We're also very concerned about our own church community. We want to be there. We want to be supportive of your decision making. And we want to be a resource to you. We know some of you may have questions that maybe you would like to ask in private, and we're happy to entertain those at any time. And so I want to thank all of our members today on the panel to provide their time and expertise to help enlighten our church congregation about the risk benefits of vaccination. And we also hope that, with God willing, that we get through this pandemic and with the least amount of pain and suffering. We don't want to see any of our members suffer in any way anymore from this pandemic. And I think the reason that we're so vocal about this now is that we have tools now. This is a preventable pandemic now at this stage in our community. And so we highly encourage all of you to consider getting vaccinated. There's no question. I think in full disclosure, all of us have been vaccinated. Many of our children have been vaccinated already. And we just encourage you to develop a relationship with your personal physician or primary care provider to discuss this further. But we're, as a church, as a fellow member of our church, representing our medical community, we want to be here to be a resource for you if you have questions about this vaccine. So thank you so much to everyone tonight. And this recording will be available to our congregation later after we edit it down. So thank you again.
Thank you, Bob and Craig, for getting us together.
Sure.
I appreciate it.
Thank you, Bob and Craig.